Okay, so you can see the question now.
Yes.
Okay, all right. So I start by first question. As we mentioned before in Mrs Fawzia sheet, there are two parts. The first part is about 135 questions, which we take it today. And the second, we take it in next Monday, is about 177 questions. You can take it in other day or 2 days. The first question, the pressure within the pleural space is negative. Of course, you know the interpleural pressure is negative during inspiration and also in expiration with respect of atmospheric pressure, except for which of the following condition. Only one exception, the interpleural can be 0 or positive. So which phase of this? End of expiration, inspiration, valsalva, whatever. So anyone have an idea?
During a Valsalva maneuver.
Yes, during Valsalva maneuver. Okay, correct. During Valsalva maneuver, of course, the venous return is more and the intrapleural pressure becomes 0 or little positive. Next question is a 30 years old alcoholic man present with acute severe upper abdominal pain and vomiting. He is admitted to the intensive therapy unit with a diagnosis of severe acute pancreatitis. 48 hours later, he developed peripheral paresthesia, carbopedal spasm. What is the most likely underlying metabolic disorder? This is not common, but one of the complication or some electrolyte disturbed due to acute pancreatitis and can cause carbopedal spasm and peripheral paresthesia. So anyone have an idea which electrolyte can cause that and what is this condition?
Hypocalcemia.
Hypocalcemia.
Yes, hypocalcemia, because as you know, calcium is decreased because of the some formation of calcium soap in the mesentery because reaction between the pancreatic enzyme and fat in the greater omentum and the root of mesentery. So the calcium is low. Although this calcium become low, but is not affect bleeding tendency simply because it is non-ionized calcium, not ionized calcium. So the patient have no bleeding tendency, but have hypocalcemia. Hypocalcemia. So the low calcium level. Next question, very common, 50 years old woman attended her GP due to change in appearance. She found difficulty removing her ring, so her hand become bigger. Report an increase in shoe size. The shoe size become bigger. And photograph refer a change in her facial appearance. Visual field test as performed to direct confirmation. What is the following defect is likely associating with this patient? So what is this patient have first?
Acromegaly.
Acromegaly. Acromegaly usually due to which part of pituitary affected or which part of the brain affected is pituitary adenoma. So in pituitary adenoma, what is the defect in the field of vision? What is the answer?
Bitemporal hemianopia.
Yeah, by temporal hemianopia due to compression by optic adenoma on the optic chiasma. Optic adenoma or pituitary adenoma is a benign tumor, but because of the space is narrow, so the pituitary adenoma compressed on optic chiasma can cause bitemporal hemianopia. Sometimes is usually or can be part of the acromegalic feature. Of course, pituitary adenoma can occur without manifestation of the acromegaly. 24 years old man fall of his motorbike, fracture of one arm, both femur, and rupture spleen. He requires surgery. 20 units of blood, big amount of blood, 10 liter. 24 hours after admission, he passed only 350 ml of urine. His blood pressure is low, 90 over 50 millimeter mercury, and he has low skin trigger. He become dehydrated. Which of the following best describe change? Okay, apart from this scenario, I need to ask you something related to physiology. So, which of the following best describe change in renin-angiotensin system? Initiate justa glomerulus apparatus of the patient. So, in trauma, in hypovolemia, renin-angiotensin aldosterone system is act. So, you can choose, of course, renin-angiotensin 2 aldosterone system. So which one you choose? We have A, B, C, D, E. So what happened and which one you choose?
All will be increased.
Okay, so it is which one? Renin increase. What about the angiotensin 2?
Increase also.
What about aldosterone?
Increase also.
So the answer is E. Renin, angiotensin 2, aldosterone, because it is cascade, like renin increase, cause angiotensin 2 secretion, cause aldosterone secretion. Okay, next question. A 35 years old woman presented to emergency department with the second attack of painful terminal hematuria. What is the most likely pathology underlying this presentation? This is question in most of the version you can find in the YouTube. The answer is UTI. But our answer is different. What you expected the answer here?
TCC of bladder.
Say again?
TCC of bladder. Transitional cell carcinoma of bladder.
No, it is 35, so he's so young. And the non-smoker and the non-working allele die. This is, of course, this is interstitial cystitis. Why interstitial cystitis? Because it is terminal hematuria. Usually terminal hematuria mean is not initial of micturition. Terminal hematuria means something in urinary bladder. Can be cancer, but this patient have no cancer, so can be interstitial cystitis. Although it is not common and occur after radiation, but can also occur alone. And we make it interstitial or cystitis, whatever, because it is terminal hematuria. If we remove terminal hematuria, remove terminal, it's just painful hematuria, so the gram-negative UTI can be correct. So again, if you found in some version they don't mention terminal, so UTI is the correct answer. If you found painful terminal, so must be something from urinary bladder, so it is cystitis. If the patient is older, so can be transitional cell carcinoma. Okay. So they just know the difference. Of course, I just tell you, in the exam, you can find the same question with little change and the answer become different. I show you in the coming question because this is very common in our exam. 60 years old man presented with short history of pain in the right cheek and the right upper teeth, maxillary sinus is diagnosed. Maxillary sinus infection is diagnosed. Sinus is partially prone to infection because of. He need to ask to tell you that why the sinus, maxillary sinus, is liable to be in the infection. Okay. We have we have 5 options. Just read the option and just tell me what is your answer. Is it due to absence of cilia, due to poor blood supply, due to position of the sinus ostium high in middle wall, relation of the first premolar and second molar teeth to the floor of the sinus?
D, position of sinus.
Okay, although this is wrong, although in the most of the version, like if you have Salah version, I think you have it, he writes the correct answer is position of the sinus ostium high in the middle wall. Is this normal or abnormal? Well, if you speak about you, it is for you like a normal person. This is normal anatomy or not normal anatomy?
Normal anatomy.
Normal
This is normal.
anatomy. So why you don't have sinusitis? This is normal anatomy. So this is also the correct knowledge, but not the correct answer. It is sometimes in exam, we write you something correct. Position of the sinus ostium high in the middle wall, it is a correct answer from anatomical point of view. But it not means that all the people they have sinusitis because of this, because it is in all people, not in this patient. So the answer here, is relation of the first premolar, second molar teeth to the floor of the sinus. So this is the correct answer. I think you read this question before. Okay. You see it before this question or just your suggestion?
I think I read
You hear
about something about the position of sinus before.
Yes. Okay. So although it is a correct knowledge, but it is not the correct answer. Okay. By the way, in the most of the versions, they write the answer is D, but actually it is E. Okay. All right. Next question. Sometimes you can find the question very long. And at the end, he asked about something silly or something not related to all this scenario, especially in anatomy and physiology question. But we can read it. 75 years old, insulin-dependent diabetes man has undergo hemicolectomy. On the first postoperative day, he is nail by mouse on subcutaneous insulin, maintain intravenous infusion of saline, intravenous morphine via BCA, patient control analgesia. He is confused after brief convulsion. His slurred speech, weakness in his right side. His pulse 110 per minute, respiratory rate 25, blood pressure 160 over 95, and saturation is 90 to 95 in the room. What is most likely cause of this convulsion and confusion? It is important, especially in old age, we have general topics or big topic called confusion post-operative. Most of this confusion post-operative is related to electrolyte disturbance, like dehydration, like over-infusion, like potassium losses due to vomiting or whatever. And in some country which is diabetes is common, can be due to what? So I show you the option is hypoglycemia or hyponatremia or something in the noradrenaline or opiate or GABA receptor. So is this diabetic patient? He's on morphine. The data is somewhat within normal, but is still in confusion. Okay, what it could be?
Hypoglycemia.
Yeah, just think simple. Confusion can be many causes. Again, we mentioned dehydration, overhydration, electrolyte disturbance, but this patient, all data is normal, so most probably this patient take a high dose or improper dose of insulin, so can cause hypoglycemia. In country which is diabetes is common, like in Malaysia, put in your mind hypoglycemia is very important topic. Even in trauma, sometimes the patient have a trauma, he fall in at his house and have head injury, simple because they have hypoglycemic attack. Okay. Next question, and is common. 20 years old woman. So first, it is young girl. Presented to the general surgical clinic with 1.5 cm cervical lymph nodes. They have lymph node, anterior border of sternocleidomastoid muscle. Clinical examination and routine blood tests are remarkable. She undergo excision biopsy of the lump as a day case. Histological report encapsulated infiltrated carcinoma with marked fibrosis and cyst exchange within the lymph node. What most likely primary pathology? So she is young, have a lymph node. This lymph node have malignant character. The lymph node is one of the upper deep cervical or upper cervical lymph node. They have carcinoma. So which carcinoma can occur in young age. Of course, he mentioned all are thyroid. I think anaplastic, follicular, medullary, papillary, lymphoma. So what it could be?
Papillary thyroid carcinoma.
Yeah, usually in the thyroid carcinoma, the only occur in age of 20 is papillary. And papillary thyroid carcinoma is multifocal. This is why if we remove the part of the thyroid, we need to complete the removal of other part of the thyroid, what we called it compilation thyroidectomy. This is characterized by empty nucleus, we called it orphan Annie, and microcalcification, we called it somoma body. So here the clue is the age. 37 years old man presented with severe headache, photophobia, neck stiffness, turning sign is positive, midline lumbar puncture is performed immediately to determine if the CSF pathology is involved. He performed the procedure. Okay, although this big scenario, but the question is different. What is the first structure pierced by lumbar puncture needle? So it is important to read the scenario like scanning faster and see the clue or the key question started from which or what or all this, and this give you the idea about what is the question. So which of the first structure we mentioned before many times, you go to skin subcutaneous. After that, which ligament? Anyone?
Supraspinous. But no
Yes.
supraspinous, so spinous.
So supraspinous ligament, intraspinous ligament, followed by ligament flavum and others. So intraspinous, supraspinous is the correct answer. Another question, and again, think simple. 26 years old woman presented with severe headache, photophobia, neck stiffness. Among other investigation, lumbar puncture is earned out. CSF sent to microscopy and culture. Culture show Neisseria meningotidi or meningococcal. What is likely predominant cell type in CSF? He mentions the blood type like macrophage, lympho, eosinophilic, basophilic, neutrophil. So this case of meningitis. So which predominant cell type?
Neutrophils.
Neutrophil. So think simple. Any infection, neutrophil is high. 70 years old woman from a nursing home presented to emergency department with abdominal pain and vomiting. On examination, she is dehydrated and her abdomen is distended. There is 3 cm by 4 cm swelling in the right groin, non-tender, and there is no cuff in impulse. At operation of femoral hernia, we found they have a femoral hernia. Femoral hernia usually don't give impulse and cuff because the space is very tiny, just a small femoral canal. So the question here is anatomy. Which of the following medial border of the hernial sac? So here write femoral artery, vein, nerve, ligament, two ligament. So what is the middle structure of femoral canal?
Lacunar ligament.
Lacunar ligament. So middle structure or medial structure ligamental canal, and laterally is the femoral vein followed by artery. Very common question, simply because the femoral hernia is very common in old people, old female. Next question, 26 years old man presented to emergency department with extensive bleeding from his arm after suturing sustained a glass injury. On examination, there is 7 cm transverse laceration across the anterior aspect of the elbow. On exploration, the cubital fossa. What you expected brachial artery to be? So here he asked about brachial artery. He need to ask its relation to medial nerve, to biceps tendon, and bicipital aponeurosis. Of course, in the answer sheet, I put a picture because this is question you must have a picture. So here he asked about the brachial artery. Its relation, for example, to if you make it a relation to median nerve. So what is the relation?
C, lateral to median nerve.
Okay, so the brachial artery here is lateral to median nerve, because if you remember, the median nerve have triple relation. In the upper arm is become lateral, cross in front, and the medial. Okay, so here is lateral to brachial. Here speak not about the medial nerve, we speak about the brachial artery. So the brachial artery is lateral here, is lateral to median nerve, because the median nerve become medial to it. So the answer is the brachial artery is lateral to median nerve, the correct answer. 52 years old man is found to have multiple myeloma. Usually this question comes the first question in exam, because they give you some sort of shock. One of the policy of exams, they put some funny question at the beginning. So he asked about multiple myeloma, because usually we don't treat multiple myeloma, it's not much important. But he asked what is the skull X-ray appearance would be characterized. So what multiple myeloma look like? It is
Multiple
osteolytic.
osteolytic lesions.
Multiple osteolytic. Yes, correct. Multiple myeloma is light chain protein abnormality in the protein, characterized by M band in the plasma electrophoresis, and have multiple osteolytic lesion. By the way, if you found this question, you found P here on in the appearance, it is for what? This one. Here on in the
Thalassemia.
appearance. Thalassemia or hemolytic anemia. Okay, so again, it is important when you answer or study through MCQ, you know what is correct and what is wrong. Next question, look easy. 50 years old woman presented with a history of right upper abdomen, upper quadrant pain, jaundice. She reported has urine become dark in color, stool is offensive and difficult to flush. What the following explain dark urine? So this is typical obstructive jaundice, typical dark urine, and the patient, why the urine is dark? Because of increase in
Conjugated bilirubin.
okay, increase in conjugated bilirubin. So this is the cause of direct urine. You can find the same question and ask, for example, why the patient have steatorrhea because of the lack of lipase, why they have pale stool because of the lack of the cercobilinogen, or why in hemolytic anemia the patient have no normal urine, because in hemolytic anemia there is increase in urobilinogen which is not soluble in urine, so don't give a color. So you can find the same scenario, and which of the following explain something is different. Something asking about urine, some ask you about stool, something about the steatory. Okay. Next question. 45 years old man presented with backache, leg pain due to prolonged lumbar intravertebral disc. The pain is aggravated by coughing and sneezing. Any spinal cord pain can be increased when you cough. Radiated to the lateral aspect of the foot. On examination, this weakness of plantar friction with root, nerve root is most likely to be involved. So it is important in the exam because we have many questions about dermatome and myotome. So he need to ask about first plantar flexion. So what is the root value of plantar flexion or myotome of plantar flexion? Plantar.
L5, S1, S2.
No, plantar flexion S1, S2, dorsiflexion L4, L5. So plantar myotomes is S1, S2, dorsiflexion L4, L5. But here he asked also, what is the radiated to the lateral aspect of the foot? So lateral aspect of the foot, it is which dermatome? Like little toe, which dermatome? Big toe,
S1.
L4. You say again?
S1.
S1. So the answer here is S1 is the correct answer. To be more important or more accurate, is better to write S1 and S2. Because S1, S2 is responsible for plantar flexion, which is here, and S1 alone for the lateral aspect of the foot. So the answer here is D. Okay, dermatome, mytome, upper limb, lower limb, at least 10 question come in exam, something direct or indirect. All right, next, and usually in exams they give you table, big table, or sometimes a funny table, sometimes it's difficult, sometimes it's easy. We try to simplify it. 62 years old woman presented to her GP with 2 week history of back pain. She lost 8 cm in height over the last 5 years. Investigation revealed. Calcium corrected 2.7. The normal value is written here, so it is within. Phosphate is 0.8, so which is low normal. Estimated glomerular filtration rate is 96, which is normal. Paras hormone is 8.9, which is very high. So what is this patient have?
Primary hyperparathyroidism.
This is primary hyperparathyroidism. Okay. Suppose I change the estimated glomerular filtration rate, I make it 30. 30. So low. So what's your diagnosis? The same other number is the same. Paras hormone is high and phosphate is in these values is within low normal, and the kidney is not good. Kidney is very bad. Renal failure.
Tertiary,
So what? Say again?
tertiary hyperparathyroidism.
No, this is
Oh,
secondary to renal failure, so we called it secondary hyperparathyroidism. If I tell you later this patient have renal transplantation and the calcium is improving, but still parathyroid is high, so it is tertiary. Okay, so we have a primary, secondary, tertiary hyperpara. Of course, in all, parathyroid hormone is high. If parathyroid hormone is high and the kidney is normal, so it is primary parathyroid, hyperparathyroid due to parathyroid gland, hyperplasia or adenoma. If the kidney is bad, so it is secondary. If after 20 years the patient have renal transplantation, so the kidney function is improved, but still parathyroid is high, we call it tertiary hyperparathyroidism. Okay? So in this question is tricky, usually come in exam, and each time they make little change. One of the big cause of failure in exam, the student just know the question and they expected to find the same like he see in these recalls. Okay, next question. 21 years old man, fracture his ulnar radius. He's treated using a plaster cast, which is removed after 4 weeks. What is the pathological process likely to have affected embolized muscle? What happened to this patient muscle? Something we called it, what we called it?
atrophy, muscle atrophy.
Yes, this is what we call the disuse atrophy occur usually if the patient have a plaster, so this is why the value of the physiotherapy after that. 22 years old man has been stabbed in the left fifth intercostal space at the edge of the sternum. Left at the edge. What's the structure most likely to be penetrated? Also left side. Which the left border or the left side of the sternum is which ventricle? This is little tricky. You need to remember the border of the heart.
Right ventricle.
Yes, although it is a left, but it is still right ventricle. So right ventricle reaches the border of the sternum in the left fifth intercostal space. 80 years old man dislocate his shoulder and it is reduced in emergency department or review 3 weeks later. He unable to active initiate abduction of the arm. So what muscle is affected? Mean which muscle is responsible for abduction or initial of abduction of the arm is
Supraspinatus.
supraspinatus nerve supply,
Suprascapular nerve.
suprascapular give supraspinatus and infraspinatus. Okay. 8 years old boy is admitted for assessment for rectal blood loss. 8 years, young. His mother described bright red in the toilet pan. He has no pain, so no pain at all. So it's not an anal fissure. No pain or defecation. There is no family history. What is most likely the cause? So this patient have bellis, fresh blood, so something come from the anus or from the lower rectum. So, and it is painless. And he's young. So what we called it?
Juvenile polyp.
Yeah, this is a case of juvenile polyp. We don't say family history because sometimes the family history, but in older, can be familial adenomatous polyposis. Of course, it is not metastasized. Next question, 48 years old woman presented with abdominal pain and 5 to 6 episodes of bloody diarrhea each day. It is important in exam. If we mention woman or man, it means that it is British woman. If I need to say something, for example, I need to speak about rheumatic heart or TB, so I write Indian woman or she a traveler from India. But if you say we don't give nationality, so it is British. So it means that 48 old British woman presented with pain, episode of bloody diarrhea, complaint of pain in the knee, elbow, and the recent visual problem. What is most likely diagnosis? So what it could be?
Ulcerative colitis.
Yeah, because it is common in England, so it is ulcerative colitis. So why he mentions that they have knee or elbow? What is we call disease?
Extraintestinal manifestations.
Yeah, extrastylian manifestation can seem to be something in the eye, like rhinosinusitis, some or also arthritis. So it is important to recognize all these. This is question also repeat many times with little change. 56 years old man presented with acute epigastric pain and vomiting. On examination, he has guarding in upper abdomen. Guarding in upper abdomen, 56. So most probably it is a case if you have serum amylase is high. So what is this case is? What's your diagnosis? Forget the other. Still we tell here. Tell here amylase is 900, so it is case of acute pancreatitis. We, in the other investigation, we need to look in for the cause of acute pancreatitis. Okay, and he gave us many options. Okay, alcohol can, gallbladder stone can, hyperpara can, hyperlipidemia can, mumps can, all are correct. But if you see this investigation, you can make it one by one. He mentioned first alcohol. So if the patient have alcohol the cause, so the alcohol most probably affect the liver. So can make affect the liver enzymes. So liver enzymes is not much high affected. Second, he mentioned cholelithiasis mean common bile duct stone. Can, but common bile duct stone, the bilirubin is 15, so it is within normal. So it is not common bile duct stone. Hypertriglyceridemia, triglyceride, back, triglyceride 0.6 within normal. Okay, so it's not the cause. Mumps can cause pancreatitis in some country, but not in countries they have vaccination and they have nothing in the picture. So what we have list hyperparathyroid. Hyperparathyroidism sometimes is not the common. Hyperparathyroidism can sometimes cause pancreatitis. Okay, so this patient have nothing in the liver, no jaundice. So the only by exclusion they have hyperparathyroidism that affect the can one of the cause of the pancreatitis. It is not the common cause, but can one of the causes. But again, all can be hyperlipidemia or triglyceride can cause gallbladder stone or biliary stone or pancreatic stone can. Alcohol can, but in alcohol can affect the liver or cirrhotic or at least hypoalbuminemia. So by exclusion, the answer is hyperparathyroidism. Although it is not common, but this is the answer. Okay. Next question. 30 years old man is admitted to ICU with isolated severe head injury. CT show multiple intercerebral bleed, no midline shift, so no hematoma. He is intubated and ventilated. Pupil dilated, react sluggish to the light. Heart rate 50 per minute. Blood pressure 170 over 110. So blood pressure is high. Respiratory rate set at 10, low. So they have respiratory rate low, blood pressure high, heart rate or pulse is low. So the rising blood pressure is due to, first, what this condition called? High blood pressure, low pulse, low respiratory rate. What this triad called?
Cushing's triad.
Cushing triad. So sometimes I ask you about Cushing triad, but here he don't ask about Cushing. He ask about why this patient have high blood pressure. Although he shocked, he may be bleed. We suppose the blood pressure is low. So why he have high blood pressure? It is occur only in head injury.
Head injury.
Yeah, head injury cause high blood pressure, but what is the explanation? It is carotid baroreceptor, cortisone, renin, angiotensin, sympathetic stimulation due to blood loss or sympathetic stimulation due to intracranial pressure change.
Sympathetic stimulation due to
Yeah.
intracranial pressure.
Yes, the explanation of high blood pressure and head injury, even if patient in shock, is sympathetic stimulation due to increased intracranial pressure. You know, intracranial pressure is 17 millimeter mercury. It is increase in head injury. Okay. Next question. Have a lot of debate. 42 years old multiparous woman admitted to emergency department due to pelvic discomfort. The duty gynecologist diagnosed as uterine prolapse. The question is, which anatomical structure gives significant direct support to uterus? If you read, all these are ligament attached to the uterus. Round ligament, muscle, broad ligament with two parts. All these ligament attached to the uterus. All these ligament supported the uterus. But all this ligament is attached to anchor. Anchor mean one point. What we call the central peroneal tendon or transverse peroneal muscle. So the anatomical structure, significant support of the uterus is the main point from which all this ligament attaches. So it is transverse peroneal muscle or central peroneal or peroneal tendon. So the answer is E. Okay, in the answer sheet, I put a picture so just to recognize what I mean. Next question is 50 years old man is admitted to surgical admission unit with central abdominal pain. His blood pressure 100 over 60, pulse 110, respiratory rate 25, is known to have severe chronic obstructed airway disease and has been heavy smoker. On examinations, they have rigid abdomen, arterial gases show. So this patient, as you see, he just gave a blood gases and he need to explanation of why this blood gases is not good, and the patient have upper abdominal pain, can be peritonitis, can be pancreatitis, we don't know. Okay, so pH here is low, so it is acidosis. PO2 is low, PCO2 is within normal, bicarbonate is very low, base excess is -3. So what's this condition? It is which type of acidosis?
Metabolic acidosis.
Okay, so it is acidosis, metabolic acidosis. So the answer, just looking for metabolic acidosis. And of course, metabolic acidosis here is not due to chronic obstructive pulmonary disease, is due to peritonitis. So the answer is C. Usually in the surgery, if have a blood gases in trauma or any condition, most of the condition have metabolic acidosis, except in the gastric outlet obstruction, still we have metabolic but alkalosis. Gastric outlet obstruction or hypertrophic pyloric stenosis or repeated vomiting, all these are metabolic alkalosis. Other condition like trauma or renal injury is metabolic acidosis. Okay, this is in describing the SAE node. Which of the following statement is correct? Of course, this conductive system in the heart and this physiology question. So SAE node is part of somatic nervous system or supplied by left coronary or in the wall of the left atrium. It is in the right, of course. It is in the wall of the right ventricle. It is in the atrium. It is received fiber derived from vagus. So what is the correct answer? Of course, it is not left atrium, it is right atrium. So CD is wrong. It is not somatic nervous system, it is autonomic nervous system.
E.
E. So it is received fiber from vagus, correct. Of course, if you remember, we have a question, maybe repeated this here. If the patient have transplanted heart, so SCA node is not connected to the vagus. So if the patient run, what is the stimulation of increased heart rate in the transplanted heart? In the patient have transplantation of the heart is not connected to vagus. But why the SCO node accelerate the heart if the patient running? Due to
It functions autonomously.
not autonomously, it is due to circulated catecholamine and hormone and the venous return. Of course, nowadays we have atrial natriuretic hormone, we have catecholamine. So the circulated catecholamine or substance due to fight or stress can have direct effect on the SCA node. So it is not autonomous, it is due to the direct catecholamine and the venous return. Okay, but within limit. Okay, a fit man, 21 years old man, admitted with an acute abdomen, subsequently diagnosed as gastroenteritis as a part of host immune response. Which of the following immune globulins cell are correct paired? Okay, so forget this patient of gastroenteritis, he need to combine the like IgA with macrophage, or this is IgD, EJM. Just if you take it one by one, Of course, IgA is secretory. It is the intestine. The correct answer here is the immunoglobulin G with plasma cell. Of course, E is for mast cell. It is for sensitivity or allergic reaction or anaphylactic reaction. M is the first anti-immunoglobulins appear, and the enzymocytes is the T lymphocyte. T lymphocyte is the cell-mediated immunity, not humoral immunity. So the answer here is IgE connected or paired with plasma cell, which is secrete B lymphocytes. Next question. 45 old man presented with fever and pain in his right loin and groin. Loin to groin, which is characteristics of the renal colic or urethral colic. A soft swelling is noticed in his femoral triangle. Diagnosed as psoas abscess. Psoas abscess is one of the complications of disease, what we call it Bot's disease in the vertebrae. What's the following statement accurate regarding psoas major muscle? So apart from this, he asked about psoas major. So psoas major muscle, so we can start one by one. First, it is just start by second. It is extend the hip, wrong. It is flex the hip. It is inserted in the greater trochanter of femur, wrong. It is inserted in the lesser trochanter. It is innervated by T12 and L1, wrong. It is innervated by L1 and 2. It passes posterior to capsule of hip joint, wrong. It is anterior to the capsule of hip joint. So the correct answer, it is arise from the lateral border of bodies T12 till L5. So T12, L1, 2, 3, 4, 5. Of course, psoas muscle combined with iliacus muscle, both combined together to go to lesser trochanter of the femur. It is important to know psoas muscle is supplied by lumbar plexus L1 and 2. Iliacus muscle supplied by anyone? What is the iliacus muscle nerve supply?
Femoral nerve.
Femoral nerve. So two muscle, same insertion. Iliacus supplied by femoral nerve, and it is the only branch above the inguinal ligament. Psoas supplied by L1, 2, which is one of the lumbar plexus. Very important question. Which one of the following muscle is extensor of the hip? So just simple question. Anatomy usually easy. Extensor of the hip is extensor being muscle of the back of the hip. So it is
Semitendinosus.
semitendinosus, because other is adductors and iliopsoas is flexor. So semitendinosus. Okay, next question, little tricky. A tall, thin, 25 old woman presented to surgical clinic with complete swelling in front of the neck in the last 4 months. On clinical examinations, swelling is left lobe of the thyroid. Multiple neuromatosis with oral cavity. Blood pressure is high, very high. Laboratory investigation show that her calcium and electrolyte is normal. So it is not parathyroid gland. Serum calcitonin is high. Phenylmandelic acid urine is high. What is the following most likely cause of hypertension? First, what this patient have? What this condition? This patient have something in the thyroid and associating with this is thyroid associating with serum calcitonin. So most probably it is medullary thyroid carcinoma. Medullary thyroid carcinoma is can be part of multiple endocrine neoplasm type 2. So this is have multiple endocrine neoplasm or MEN2. What is VMA, phenylmandelic acid? What is this? The end product of what?
Catecholamines.
Yes, the end product of catecholamine. So this patient, catecholamine is secreted from adrenal medulla. So this patient have the cause of hypertension is what the condition causes this hypertension? Okay, so this patient have multiple endocrine neoplasm type 2 which can run in family, autosomal dominant, associating with medullary thyroid carcinoma. The tumor marker is calcitonin. Sometimes also can be associated with parathyroid adenoma and also have pheochromocytoma. The end product of pheochromocytoma is metformin in the blood, and the end product in urine called vinyl mandelic acid. So the answer is pheochromocytoma. Okay, autosomal dominant disease. So I just come here. What other in the urine? We have 3 marker. What other tumor marker you can find in the urine? First, in Benz-Johnson protein, we have a tumor marker. Benz-Johnson protein, it is in the multiple myeloma. We mentioned late. So the first tumor marker, Benz-Johnson protein in multiple myeloma. Second, vinyl mandelic acid in pheochromocytoma. Third and the last is carcinoid tumor, which occur in tip of appendix, which secrete serotonin or 5-hydroxytryptophan. This end product of 5-HT is 5-HIAA or 5-HIA or 5-hydroxyindole acetic acid is the end product of the serotonin. So 3 urine marker for tumor, PMA for pheochromocytoma, 5-HIA for carcinoid tumor, Benz-Johnson protein for multiple myeloma. Okay, next question. About 65 years old man presented with hematuria, left loin pain, computerized tomography demonstrate left renal tumor. He's undergo left radical nephrectomy. Where does the left renal artery lie? So forget all the scenario. This is like anatomy question. Left renal artery. So left renal artery, if you remember, the vein, the artery, the ureter, more posterior. So the artery is. Of course, we start by vein, so the artery must be in relation to the vein. So it is
Posterior to left
posterior.
renal vein.
Okay, so left renal artery is posterior to left renal, and as you remember, the left renal artery cross to go to the inferior vena cava in front of the aorta. Within the posterior triangle of the neck, which nerve is particular risk damage during surgery? Very common question, very common complication. If you take a lymph node, occipital lymph node, or posterior triangle lymph nodes, you can injure it which nerve?
Spinal accessory. No.
Spine, and it is give which muscle? 2 muscle, which is
Trapezius and sternocleidomastoid.
okay. Just the 2 muscle. All right. This is very, very common question. I don't know why. The right and the left pulmonary arteries is derived from which of the following embryological aortic arches? Of course, as we remember, we have 6 aortic arch. 2 is rudimentary, and usually the question ask about right and left pulmonary artery, or sometimes they ask about ductus arteriosus, and both arise from which arch? 6 aortic arch is, remember, if you review the thorax topics, I will have summary for some of the embryological important embryology, so I will send it to you in our group, by the way. Okay, next question. 47 years old man presented to emergency department 6 hours after clamping accident. Initial assessment suggests he had lost 1 liter of blood. Blood pressure 105/70 millimeter mercury. His pulse is 88 per minute. Castrated, and the bladder contain 100 ml per unit. Okay. Apart from this scenario, it is physiology question. He asked, activate of which of the following transport system describe how aldosterone lead to maintain intravascular volume and oliguria in the man. So he need to ask about aldosterone. First, aldosterone act in which part of the kidney?
Distal convoluted tubule and also the collecting duct.
Okay, so aldosterone act distally, so distal convoluted and the collecting duct. Of course, mainly in the collecting duct is antidiuretic hormone. Aldosterone act in salt water retention. Okay, so sodium chloride wrong. Lubofenin wrong. So the answer here is sodium and
Potassium.
yeah. So the answer here, he act on distal or collecting tubule in the sodium and potassium system. Of course, it is salt and water retention. During aortic angio, vertebral artery seen arise directly from the which of the following? See direct anatomic question. Vertebral artery arise from
Subclavian artery.
which part?
Uh,
First part of subclavian artery. Vertebral artery combined with other vertebral artery to form basilar artery, and after that enter of the circle of Willis. Okay, next question come many time, and each time they have a little change. 65 years old, remain on high dependence unit or HDU following gastrectomy. 3 days previously, his urine output has averaged 80 milli per hour for the last 24 hours, very little. He has 1 day abdominal drain, one dry abdominal drain with no nasogastric losses or no nasogastric tube. His urea electrolyte normal. He say nil by mouth in further 24 hours. What the following fluid regimen is most appropriate to his electrolyte and water requirement over the next 24 hours? So he just need to ask you which type of fluid to give this patient post-operative. So we have saline dextrose, we have saline dextrose, we have Hartmann and saline, and we have dextrose and saline, and have saline alone. So what you prefer?
A.
Which one?
Saline plus A. Saline plus dextrose and also the saline.
All right, of course, we don't give 0.18 saline. This is wrong. So the answer in this patient, we give saline and dextrose. I think last year they have little change and say this patient have nasogastric tube and this nasogastric tube have a lot of discharge. If the patient have nasogastric tube, so what we give, you need to give something rich of potassium. So which fluid you give? We add Hartmann solution. So in this question, the answer now is saline and dextrose. 1 liter saline and 2 liter dextrose. But if say this patient have nasogastric tube and have a lot of losses from nasogastric tube, so you need to add saline and Hartmann solution because Hartmann is fluid rich of potassium. So again, the same question, but just a little change, the answer become different. Next question, and also common, 3 years old boy is admitted to hospital with severe vomiting. Radiographic examination reveals that suffering from annular pancreas. Annular pancreas of one of anomalies in pancreas. So you know the pancreas is the curvature of duodenum. So which part affected in duodenum by annular pancreas from anatomical point of view? It is
Second part of duodenum.
is second part of duodenum. Yes. Okay. Next question. Okay, next question have some debate, but I tell you what is answer, what is the other answer. 20 years old man, severe head injury, ventilated using intermittent positive pressure ventilation. which is PEEP. What's the following physiological consequence of this? Okay. Our answer, and it is reviewed by the anesthesia, the answer is decrease cardiac preload. In some version you can see in the YouTube, they write increase cardiac preload. But the correct answer is decrease cardiac preload. Okay, I don't know why they put the explanation, but it is decrease cardiac preload. Of course, it is important to know again in the PEEP system can increase the venous, can affect the venous return, increase the venous return, not decrease the venous return. Okay, so if the increase the venous return, so it makes that decrease the preload. So the answer is decrease the preload. Here it is intermittent, not continuous. So this is why if we don't intermittent can affect the cardiac preload can be increased. But because it is intermittent, so it is decrease the cardiac preload. Okay. So decrease because of the venous return is decrease. So the answer is decrease, not increase. All right, it is clear. It is like when you measure, suppose this patient is connected to central line. What you expected the CVB of this patient? If this patient connected to central line CVB, so it is high or low?
Low.
No, it is high. It is one of the false high CVB. You know that in the indication, if you found in the causes of high CVB, one of the cause is a patient on ventilator. Second is constrictive cardiomyopathy or pericardial tamponade or all these because like congested neck vein. So the usually patient on beep ventilation or in ventilator, the central venous pressure is false high because it is affect the decrease the venous return, decrease the preload. Preload means right side, of course. All right. 36 years old man presented with 2 months history of low backache, radiated to the left leg. After clinical examination, referred to MRI. This show prolapsed intraventricular disc. Clinical signs are consistent with pressure on S1. Which combination of clinical sign is most likely? Okay, so this patient, the important in this question or this type of question to know the reflex values. Like for example here, weakness, ankle parental, alter sensation of dorsal foot, normal ankle jerk. Okay, ankle jerk is S1 and 2. Second, weak ankle plantar, alter sensation on the sole, not the dorsum of the foot. And loss of ankle jerk. So here normal, here loss. So this patient have pressure in S1. Ankle jerk is S1 and 2. So the correct answer is B because loss of ankle jerk. And also S1 cause the sensation in the sole, not in the dorsum of the foot. So this is usually important to know dermatome and dermatomes because question like this is very common and the only explanation or answer can be easy done by dermatome and dermatome. Again, simple question, 55 years old woman undergoes cholecystectomy. Gallbladder contain multiple dark pigmented irregular small stone. The most likely cause of this type of gallbladder stone is increase in blood level of what? So this pigmented stone, because the patient had hemolytic anemia, most probably because hemolytic anemia can cause pigmented stone. So in hemolytic anemia, which type of bilirubin is increased?
Unconjugated bilirubin.
Okay, so here the answer is unconjugated bilirubin because the hemolytic anemia can cause pigmented stone. But suppose in the same scenario and they say this patient suffer from obstructive jaundice, so at this condition, the cause of obstructive jaundice can cause increase of the direct or conjugated bilirubin. Again, cholesterol stone can occur in the gallbladder, but not related to cholesterol level. Next question, 41, 55 years old man presented with deep venous thrombosis. Full blood count show hemoglobin is very high hemoglobin. White blood cell count of 8.10 into the power 10. Not very high. Platelets count, no, white blood cell is within normal. Platelets count 200 is within normal. Hematological picture is most likely associating with. So this patient have condition called polycythemia. Polycythemia can be one of manifestation, what we called it paraneoplastic syndrome. So this patient have polycythemia due to what? Which disease can cause polycythemia? Which
Renal cell
tumor?
carcinoma. Renal cell
Renal
carcinoma.
cell carcinoma can be one of the triad of the painless hematuria, renal swelling, and in some patients have left varicocele if the male, and have polycythemia. Polycythemia is dangerous because polycythemia can be the cause of deep venous thrombosis or thrombosis complicated by pulmonary embolism. So it is renal cell carcinoma. Sometimes in a small cell carcinoma, not bronchial carcinoma, small cell carcinoma of the lung can also be presented by high erythropoietin or sometimes by high parathormone. 27 old has pancolitis. Pancolitis is common with ulcerative colitis for the last 5 years. Which one of the complication is least likely to develop? Least likely is not common, likely to develop. So we can start one by one. Patient have ulcerative colitis, so toxic megacolon can occur. Arthritis like ankylosing spondylitis can occur. Sclerosing cholangitis can occur. Iritis, eye manifestation can occur. What is D? What mean by D? What it mean?
Multiple inflammation of the small arterial, polyarteritis
Yes, so
nodosa.
it is arthritis. All right. So it is wrong. But usually in the exam, we have something called visual hallucination because I can read it like polyarthritis. It is look like polyarthritis, mimic like visual hallucination. So it is not arthritis, of course, it is arthritis, like temporal arthritis. So the ulcerative colitis don't affect the artery. So least likely is polyarthritis. So just remember it is polyarthritis, mean artery, not arthritis. Okay. Next question, a surgeon make Philistine incision for access of pelvic organ. He incised the abdomen wall down through rectus sheath. Rectus retract the rectus abdominis muscle laterally from the midline and exposed. So which layer? Skin, subcutaneous, rectus abdominis, retract rectus abdominis, below umbilicus. So you found
Transversalis fascia.
transversalis fascia because below the umbilicus we don't have posterior rectus sheath. Just the anatomy. 25 old undergoing splenectomy following blunt abdominal trauma, 3-day post-operative venous blood test is likely to reveal. Of course, it's a removal of spleen. You can find many anomalies usually abnormal RBCs, usually something called Heinz cell, reticulocytes, and other. Is not important because it takes time and after that become with normal. But what is dangerous after splenectomy is increase in number of what?
Platelet.
Platelets. What is the dangerous if platelets increase?
Thrombocytosis.
Yeah, can cause some sort of thrombus, what we call the white thrombus, and they can cause thrombosis, so it is dangerous. And at this time, we give the patient aspirin. Aspirin don't decrease the platelets, but prevent the platelets aggregation. Okay, next, 46 years old woman is seen in pre-admission clinic. She had myocardial infarction 2 years ago. On examination, they have AF, atrial fibrillation, and the recent echo shows that dilated left ventricle. She is on warfarin and INR 6.1, so it is very, very, very high. Maybe not happened. Does warfarin? So the question now, warfarin inhibit which of the following? So warfarin is oral anticoagulant, act on the extrinsic pathway, and it is inhibit anyone?
Prothrombin.
Prothrombin. Okay. Of course, it is important to know the oral anticoagulant. Warfarin act in the extrinsic pathway. Antidote of it is vitamin K, prothrombic concentrate, and the fresh frozen plasma. 75-old man is admitted to elective repair of abdominal aortic aneurysm. Following operation, his systolic blood pressure fall 90 millimeter mercury. During resuscitation, is giving an infusion of fluid. There is a choice of colloid or crystalloid. Which of the following best described way the intensive therapy unit registrar decided to admit? So this patient have hypotension, due to massive bleeding or massive surgery in aorta, so he needs something to increase the blood volume. So he choose colloid. So why he choose the colloid? Because colloid is or are it stay time, because if you give any fluid like saline, like glucose, is don't stay in the circulation long time, so colloid is a stay long.
Colloids not freely permeable across semi-permeable membranes.
Yeah, the A colloid is not freely veltable across semi-permeable membrane, so it take a time, so it stay long time in the circulation. Okay, next question. 35 years old, they develop septicemia following surgery of perforated acute appendicitis. His hypotensive arterial blood gases show pH low, acidosis, PO2 low, BCO2 high, bicarbonate low. So this is a case of course, acidosis. Which type of acidosis?
Metabolic acidosis, uncompensated.
It is metabolic acidosis, yes, but it is you mentioned no, it is metabolic acidosis mixed with respiratory acidosis. Okay, so the answer is C, mixed metabolic and respiratory acidosis. Of course, it is acidosis, but not compensated, is mixed. Okay, agree?
Yes, need to count the anion gap.
Okay, all right. All right. By the way, your answer is uncompensated metabolic acidosis. Yes, the first answer.
Yeah.
This is the answer also in the YouTube, but it is wrong because this is question we review with the anesthetist. So the answer is C, not D. I just write in my notes that if you found something is different from the other YouTube channel, so I write it here. Okay, so the correct answer is still mixed. Usually ionic gap, we don't collect it in the practice, I think. Okay, but trust your answer. Okay. Next question, 20 years old man presented to emergency department, stab injury in thenar muscle. On examination, they found have 2 cm long laceration, loss of sensation, thumb and index, and the weakness of the thenar muscle. So here you have a trick. Of course, thenar muscle supplied by medial nerve. And we know that medial nerve, the motor part pass in the flexor retinaculum, but the sensory part pass in front in the over flexor retinaculum. So this patient have motor and sensory losses. So the answer is he have sensory and the motor branch of medial nerve. In the carpal tunnel, may be affected mainly the muscle, but sensation is still intact. So this is injury of both. Next, again, dermatome, very important. 65 years old man presented with vomiting, weight loss. On examination, they have had three bulbal epigastric mass. Forget that. Transpyloric plane laid at the level of what? Okay, so the question now about transpyloric plane. Where is that? What is the transpyloric plane? Is level of
1.
okay, L1. Okay, I think this is 3 is a bulbable, not 3. Okay. All right. 30 years old motorcycle is brought to emergency department after RTA. He has an open fracture right femur. On arrival, tachycardia, confused, cold, clumpy skin. Which of the following physiological change is most likely to occur? So this is physiology question. He asked what is the patient of shock, cold periphery. So it is due to what is the following physiological change? Okay, so he speak about electrolyte. All right. So what happened to this patient? It is, of course, in trauma, it is metabolic acidosis. So which item here with metabolic acidosis? Of course, not increase pH, it is decrease, so it's not correct. So which one of these is with metabolic acidosis?
Boy, decrease serum bicarbonate level.
Yes, decreased serum bicarbonate. So we're looking for metabolic acidosis. pH is low, not mentioned here. So it is decrease in the serum bicarbonate level. Correct. In emergency, what is the most appropriate surgical methods to obtain an airway? Emergency situation. You are in emergency, you are not much expert. Tracheostomy take a time. Endotracheal tube maybe need some experience, you are not have it. So what you will do? Okay, we have many options. What is the fast done in emergency?
Pierce the cricothyroid membrane.
Okay, so the easy way for non-expert is the cricothyroidectomy. Just piercing the cricothyroid membrane is easy, fast, have a special needle. Of course, tracheostomy take a time. Endotracheal tube need a little experience. Maybe you are in stress, so cricothyroidotomy is the easy, rapid way. Again, to dermatoma and dermatome or something like level, 75 years old man presented with hepatomegaly, ascites, CT, evidence of post-hepatic portal hypertension. And the question is, the inferior vena cava pass through the diaphragm at which level? Vena cava, just remember vena cava, if you count the number of letter in vena cava, it is how many letter?
8 letter.
8, so T8. So the easy way is T8. So the answer is T8. Just count vena cava. 20 years old woman presented acutely with abdominal pain. Imaging reveal right ovarian cyst lesion, which exercise histological examination shows cyst lining by keratinized raphe squamous epithelia, which is abnormal cell here. Area of fat, muscle, thyroid, neural tissue, which is ectoderm. So they have ectoderm, they have some endoderm. So what is the appropriate pathological this distinction of this lesion? So this lesion, we call it totipotent, or they have a multiple cell of origin. So what we called it? Sometimes they found the teeth, they found ectopic teratoma. So ovarian teratoma, although it is rare, but usually funny, found in most of museum. So in the ovary, you can find the hair, which is ectoderm. You can find the skin, which is ectoderm, teeth, some endocrine cell. So it is called teratoma or characteristic for this. All right, 25 years old woman is 2 months postpartum, presented with a tender mass in left breast. Pyrexia, raised white cell count, C-reactive protein, diagnosed as lactating mastitis with abscesses made. Okay. Which of the following is most likely causative organism? So just a simple, patient have breast abscess or breast mastitis, so the organism is simple question, simple organism, skin commensal or skin organism, sure it is.
Staph aureus.
Yeah, just think simple, so it is a Staph aureus. Okay. 62 old alcoholic, mean drink alcohol, admitted with severe acute pancreatitis 3 days after admission has become hypoxic. PO2 is 7.5 kilopascal. To confirm from kilopascal to millimeter mercury, just time 8. So by 8, so it is about 60 something. Confused, chest X-ray show uniform obesity of the both lung. So what is your diagnosis? It is a case of
Adult respiratory distress syndrome.
yeah, one of the complication of acute pancreatitis is ARDS. Can also cause acute kidney injury, so can find the patient deteriorated. This is why one of the line of treatment of the acute pancreatitis, you give the patient oxygen. Next question, 58 years old woman presented to the emergency department with large fluctuated swelling at the site of recent insect bite. She is anxious, tachycardia, pyrexic, ECG show critical fibrillation. She is noticed to have a goiter. The swelling is the site of the bite, requires surgical drainage. Which of the following drug most appropriate as a part of pre-operative preparation of the surgery? Of course, this patient can be considered as septic shock. Forget the goiter because it's not mentioned about toxic goiter. But pre-operative preparation of this patient, just to relax, to avoid effect of fibrillation, so what you give to her? If the patient in stress, what you usually give? If the patient's like, suppose it is thyrotoxicosis, what you give?
Beta blocker.
Beta blocker, so we give beta blocker. Yes, correct answer. But suppose the patient in severe hypotension, what you give?
Adrenaline. Severe
Adrenaline, so
hypotension.
it is alpha adreno agonist. Okay. So in the severe hypotension, we give adrenaline. In the patient stress, you give beta blocker. All right. Next question. Next question have two version. Okay. If this patient, all right, okay. Nalibara, 30 years old woman, presented with a recurrent painful red area in the areola. She gave a history of smoking cigarette. The lesion excised and histology shows squamous metaplasia. Squamous metaplasia in the breast is not precancerous. It's not like Barrett esophagus, which is metaplasia. Here is not precancerous. Biological culture don't show any organism. What the following is the most likely diagnosis? So here we have two clues: smoker and young, because we have a smoker and old. A smoker and young, what's your diagnosis? Smoker and young.
Subareolar abscess, periductal
Periductal
mastitis.
mastitis or something. Okay, suppose this patient is 50 years, chronic smoker, have the same condition, what we called it? 50. The same presentation, everything is the same. We called it tachyctasia. So we have two scenarios. Nelly Bara, 30, chronic smoker, have something in breast, not like abscess. So we called it subaerial abscess or periductal mastitis. If older, smoker, so it is called tachyctasia. Both we give antibiotic for aerobic and anaerobic because usually it is anaerobic organism and is difficult to treat. So this is what we call the subaerial abscess, periductal mastitis. In the past, in all the books, they called it plasma cell mastitis, which is wrong name. So is this ductectasia in older, non-lactating? In the young, it is called subaerial abscess. Okay. It's very common question, and usually sometimes they make it 30, sometimes make 50, so just to notice the difference. Next question, 65. Years old man undergo right hemicolectomy. On the second post-operative day, he is febrile. Nausea, distended abdomen, little pain. The intravenous morphine via patient control anesthesia, PCA. Plain X-ray confirmed distended lobe of small intestine, and this is usually due to ileus because one of the complication of the morphine is paralytic ileus. The physiological basis of post-operative ileus is so morphine cause ileus due to stimulation of what?
Suppression of muscarinic receptors.
Okay, good. I see in the YouTube also some correct this P make it mu. Stimulation of mu receptor is correct, but here it is P. So mu receptor is muscarinic receptor. So in morphine affect muscarinic receptor correct. Suppression of muscarinic receptor is correct. Stimulation of mu receptor is correct, not P. So this suppression of muscarinic receptor. 42 years old woman has cholecystectomy, develops self-limited post-operative wound infection. By what process would the bacterial ingestion have been enhanced? This is also tricky. What is the answer? Just wound infection, simple wound infection. You have a bacteria. This bacteria is engulfed by the process, what we called it?
Opsonization.
No, wrong. You read it in other version. Okay, I tell you why it is wrong. Opsonization occur in which part of bacteria? Capsulated or uncapsulated?
Capsulated.
Capsulated. So capsulated is common to cause wound infection.
No.
What is the common organism cause wound infection is the staph. So this question, this patient post-operative have wound infection by staph, so the process is called phagocytosis.
Phagocytosis.
Okay, I have another version of this question. This patient post-operative wound infection by Klebsiella pneumoniae. And you know that Klebsiella is capsulated organism. What is the answer? Opsonization.
Opsonization.
Okay, so I tell you the difference now. So the difference, if the patient have wound infection by capsulated organism, which is rare, so it is called opsonization. If the patient have wound infection by normal organism, which is common, it's called phagocytosis. Phagocytosis and opsonization is the same process of phagocytosis. The only exception in opsonization, the spleen secrete ospin, and this ospin coated the bacteria, makes the macrophage to easy engulf the bacteria or the organism. This is why in some book it is called like, it is like ketchup, like sauce we put in the food to become easy to eat or become tasty. So this is what is the function of opsin. Because I think who speak his read also in the YouTube, because in this question in the YouTube channel have two version. If I mention Klebsiella, so it is encapsulated. The correct answer is opsonization. If we don't mention just wound infection, so it is phagocytosis. By the way, I don't need to make you in panic. One of the common cause of the wrong answer in exam, because you see the question before and you stick to the answer and you know what is this answer is correct and what this answer is false. Okay. By the way, this is very common question. 60 years old, non-smoker. So non-smoker, so no obstructive airway disease, no respiratory something. Presented with 3 months history of loss of weight, malaise, and breathless. On examination, he has left supraclavicular lymph node, so which is Furchow or Furchow lymph node with malignancy. A chest radiology revealed multiple bilateral obesity, can be with malignancy. What abnormality would biopsy of the left supraclavicular most probably show? So at the end, this lymph node is benign or malignant? Malignant. So it is not granuloma, because granuloma is with tuberculosis, not inflammation, not Langerhans cell or giant cell for granuloma, not Rend-Stringberg for Hodgkin lymphoma, because this is just a lymph node, not generalized lymphadenopathy. So it is just multiple abnormal mitotic figure of the cell, just malignant cell. Of course, if you mention it is multiple lymph node and they take a lymph node and the patient is young, so can be Hodgkin lymphoma, so it is Rend-Stringberg cell. Of course, in exam, some question very, very easy, some question take a time. So this is why in one question you can take 10 seconds, some question you take more than 1 second. 70 years old woman with emphysematous chest receives 60% oxygen by mask, has following blood gases. Result is most likely interpretation. So pH also acidosis, BO2 low, CO2 high, bicarbonate very high, base excess is positive. So this is something compensated. So it is acidosis. What type of acidosis and what happened?
Partially compensated respiratory acidosis.
Why respiratory? Yes, correct. But why respiratory? Because
The partial pressure of carbon dioxide is high, and the bicarbonate is to compensate for it.
okay. So the answer is partially compensated respiratory acidosis. Correct. 2 years old child referred because impalpable testes in the left scrotum. Which is the following position describe ectopic testes? This also have a lot of debate. So I will ask you, because you tell me the answer in the YouTube. What is your answer?
Ectopic testis, so at the base of the penis.
At the base of penis, correct answer. So ectopic is away from the normal pathway, so at the base of penis. In some also they write root of penis. It is not the root, it is the base. The other YouTube channels, they make the answer is superficial inguinal ring, which is wrong. Still, superficial inguinal ring is considered as undescended testis. But they give this answer because in the Wikipedia or some of the public make a picture and make superficial inguinal ring is ectopic, not undescended, but actually it is in anatomy, in anatomical book, it is still undescended. Just if you see that, if you Google to see it, it is wrong. 60 years old man is found to have 2 cm diameter mass in upper lobe of the left lung. Usually upper lung swelling is usually can be TB, but here we see the lesion excised and found include connective tissue, mature cartilage, ciliated epithelia, so they has multiple tissue, so it is not TB. So what it could be?
Hamartoma.
Hamartoma. Hamartoma is abnormal, is normal cell but abnormal arrangement because connective tissue, because all these are normal cell in the lung. So the hamartoma is normal cell but abnormal arrangement. If this cell is not found in the lung, so can be teratoma. But this is because the normal cell of the lung, so it is hamartoma. Hamarton mean bizarre or puzzle shape. Very rare question. 23 years old man presented with 3 months following extraction of the caries teeth and the plague-like infiltration over upper jaw and sinus formation. Yellow granule, like something like yellow sand, is present. So this yellow sand is characteristic of which disease? Rare disease. What this disease called?
Actinomycosis.
Actinomycosis or actinomycosis occur in 3 parts of the body. In the jaw, what we called it orophacial. Second, in the lung. Third, in the ileocecal area, like ileocecal TB or ileocecal actinomycosis, although it is rare, but can the cause. Next question, 65. 82-old man complete occlusion of inferior mesenteric artery on angio. This is common nowadays because they insert something called the EVAR in the aorta, they obstruct the inferior mesenteric. But the patient have no symptom of ischemia. Which of the following arteries is the most likely addition source of blood supply to the territories of the inferior mesenteric? You already closed the inferior mesenteric, so why is this part of colon take a blood supply? From where? I have the picture here. So they close inferior mesenteric. So superior mesenteric, they have a branch here. So what is this branch? Is branch from?
Middle
We have
colic
right
artery.
colic, middle colic. So the answer is middle colic. So the middle colic arteries have right and left branch. The left branch make arcade with some of these, so it can give the blood supply. This is now very common because we insert the EVAR here, and the EVAR have no hole for the inferior mesenteric. So inferior mesenteric usually occluded. Of course, we don't occlude the superior mesenteric and the renal because usually aortic aneurysm is below renal. An intravenous drug abuser is having echo for suspected endocarditis. Closure of tricuspid valve occur at the onset of switch phase of cardiac cycle. This is physiology question. So he just needs a closure of any valve, usually occur in isometric or isovolumic phase. But he asked about closure of tricuspid valve, so it is closed at isovolumetric or isometric contraction phase. So the answer is B. Next question, after being stabbed in the left groin, previously healthy 20 years old man admitted to emergency department, he developed hemorrhagic shock. During resuscitation, again 10 units of type O negative blood, 6 liters of colloid. 24 hours later, he noticed have severe dyspnea for which require intubation and ventilation. So this patient take about 10 units, so 5 liters. He take 5 liters of colloid, 11 liters. So if your patient is normal and take 11 liters, he will die because of pulmonary edema. So it is not good, by the way. Don't give this 11 liter to the patient. But what happened to this patient? What happened if the patient have a trauma? Apart from giving fluids, what happened to his lung? What's this condition called?
ARDS.
Yes, it is ARDS due to excessive. Usually, if the patient take a lot of blood, he can have ARDS or can sometimes have DIC. So they usually must be under control. Of course, in aortic aneurysm, aortic abdominal aortic aneurysm, the patient have a loss of blood, so it is can be easy compensate. 80 years old man with a history of hypertension controlled with the side diuretic undergo transurethral resection of prostate under general anesthesia. The surgery is prolonged and recovery room he complained of nausea and headache. Later become agitated and confused. We mentioned before post-operative confusion can be due to excessive fluid, can be due to electrolyte imbalance. Usually, one of the common after TURB is something called TURB syndrome due to excessive fluid, and this TURB syndrome can cause pulmonary brain edema. If you leave it, can cause pulmonary edema, and the patient died. But this is edema or excessive fluid affect some electrolyte. Which electrolyte is affected if they give a patient a lot of fluid?
Sodium hyponatremia.
Yeah, this is what we call the dilution hyponatremia. So hyponatremia is the common cause of confusion, especially after TURB, transurethral resection of prostate. Okay, next question. 35 years old man admitted to the hospital vomiting, nausea, severe headache, and MRI scan revealed tumor in cerebropontine angle. It is anatomy question. Just remember cerebropontine angle in the anatomy have two important cranial nerve. What is this two cranial nerve? Is something related
Facial
to ear?
and
Okay, facial and
vestibulocochlear.
vestibulocochlear. So in acoustic neuroma, which is a benign tumor, can also affect the facial and vestibulocochlear. Very, 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 very important. Next question is tricky. After resection of rectal tumor, resection of rectal tumor, this operation, what we called it, abdominoperineal resection, AB resection. The same procedure also can occur in rectopexy, which is fixation of the rectum in rectal prolapse. This patient experience impotence, erectile dysfunction, which is the following nerve damage in this surgery. It is important to know erection is parasympathetic. Ejaculation is sympathetic. So, which nerve of this list is parasympathetic? Not motor,
Pelvic
not
splanchnic
sympathetic.
nerves.
Okay, other name of this nerve? Pelvic splanking nerve. Sometimes they called nervi argenti. It is parasympathetic. It is preganglionic parasympathetic. So if come preganglionic, not postganglionic. Preganglionic parasympathetic, correct. Nervi argenti, correct. The same nerve. The correct name is pelvic splanking nerve. So it is parasympathetic, not sympathetic. Not hypogastric nerve, because in some versions they say hypogastric nerve, not the correct answer. 45 years old woman presented with pain, swelling, stiffness, affect all metacarpopharyngeal joint. She has noticed weakness in her grip and handwriting has changed. Is unable to extend the finger fully. So here something in the extension. Index, middle, ring finger of both hands show an ulnar deviation. So what is this case? This patient have small joint of the hand with ulnar deviation. So the diagnosis is
Rheumatoid arthritis.
yes. Sometimes they ask about the histopathology of rheumatoid arthritis, and it is something called the necrobiogranuloma. You can find in other exam. 22 years old man arrived to emergency department with sudden breathlessness due to large pneumothorax. Chest drain is inserted in the fifth left intercostal space. Nowadays, even tension pneumothorax decompression done in the fifth intercostal space left side. The hemorrhage, there is a hemorrhage. Hemorrhage, I think they have some hemorrhage into the drain bottle. With the following structure is most likely cause acute hemorrhage. Okay, so you need to ask about this patient during insertion of the tube, the patient insertion of the needle or the drain, chest drain, they have a bleeding. So he inserted in the intercostal space, which artery in this area. Of course, it is important to insert it above the rib, not below the rib, because if you insert it below the rib, you can injure it. Which vessels? Anyone?
Intercostal vessels.
Intercostal vessels. So the answer is intercostal vessels. Okay. 65 old woman collapsed after total hip replacement. Pulmonary embolism is suspected. We ask about what is the ECG change of the pulmonary embolism. Of course, it is important to know in the pulmonary embolism we have something mimic like called S1 Q3 T3. S1 mean S wave in lead 1. Q3 mean Q wave in lead 3. T3 means a T wave in T3. So again, S1 Q3 T3. I don't found S here. I don't found the Q also. So only T. So the correct answer is T inversion in the V1 and 3. Pulmonary embolism picture is very common. I have also one file about the ECG important from surgical point of view, which is little. So I will send it to the group. 40 years old woman has had anterior lobe of pituitary removed because of the tumor without post-operative supplement. Of course, anterior pituitary have many hormone. What is the following could occur? Anterior pituitary. So anterior pituitary, you have something called TSH, thyroid stimulating hormone. So if there are no TSH, so no thyroxine. So the following is failure to produce adequate thyroxine. Okay. I will stop when I complete 2 hours. So I stop at 10. So don't be worried. 38 years old man is an end-stage renal failure resulting from polycystic kidney. Polycystic kidney can be autosomal dominant disease, can run in family. Receives a cadaveric renal transplant. Good renal function established, but 4 weeks later, serum creatinine rise by 20%, so it is not good. Which of the following process likely responsible for this deterioration? Okay, so as we mentioned before, we have hyperacute, acute, and chronic. And we mentioned that hyperacute is within hours due to incompatible blood transfusion, which is type 2 hypersensitivity. But this what happened here is after 1 month. So if it is after 1 month or within 1 month at the end of this month, so it is cell-mediated immunity. So type 4. So this is type 4. If occur later after more than 1 month, so it is type 3, which is immune complex or vasculitis. So again, the rejection is hyperacute, acute, chronic, type 2, type 4, type 3. If occur within 1 month, so it is cell-mediated rejection. So it is T lymphocyte. So the answer is T. T cell mediated rejection. What we called it acute rejection occur within 1 month. Okay. Next question. To exposed right axillary artery, a transverse skin incision is typically made below the clavicle from point just lateral to the sternal end to deltopectoral groove. What is the following structure encounter in the section down to the vessels? This is very common question. If you see this picture, you can find a small, tiny blood vessels, maybe not famous. What we called it sacroacromial artery have 4 branches, and these branches is very tiny. Although it is not important, but it can cause a lot of bleeding, especially in axillary or axillary clearance in cancer breast or mastectomy, and also in the trauma in this area of deltopectoral groove. Of course, we ligated all these branch is have no effect because it's not important branch. Here we have a trick because speak about right side. And we mention here thoracic duct, and thoracic duct, of course, in the left side. And again, all these vessels is away from our position. The only is related sacroacromial artery. Okay, next question is 4-year-old boy presented to emergency department with 2-day history of headache, vomiting, drowsiness, CT scan dilated both lateral and third ventricle. His fourth ventricle is normal. So here abnormal or something narrowing is the connection between lateral and third. So this is a duct connected both and can cause the obstruction. The duct connected lateral and third is called aqueduct of Sylvius. And again, Lushka, foramen Lushka is lateral for drainage, and Magenti is median foramen for drainage. So this is our drainage. But the connection is by aqueduct of Sylvius or cerebral aqueduct. Okay. A 12 years old boy presented to emergency 2 hours after helping father cut the grass. He complained of rhinorrhea, itching, eye, sneezing, blocked nose, apyrexia. Hemoglobin is normal, white blood cell is within normal, and raised eosinophil. Of course, eosinophil is raised in parasite infection, which is not common in England, so it is not important in our issue. And also in allergy. Chest X-ray is clear. So this is allergic condition. So if it is allergic condition, so which immunoglobulin appear with allergy?
IgE.
IgE. So usually in allergy, IgE. Okay. This is can be the maybe last question. 35 years old woman undergo gastric bypass surgery for morbid obesity. After subsequent surgical clinic review, she complained of dizziness, sweating, palpitation, collapsed episode after a big meal without any vomiting or pain, otherwise well, and has no medical problem. What is the most likely explanation of this symptom? This is, in the past, we have gastrojejulostomy done for peptic ulcer. Nowadays, we don't do this operation, but when bariatric surgery is appear, so we have what we called it partial gastrectomy and gastrojejulostomy, or connect the remnant of the stomach to the jejunum. So what we called it, the blood sugary food is just come faster to from the part of the stomach to the jejunum, so increase the level of glucose. After that, the insulin is secreted more, so the hypoglycemic, so the patient have hyper, then hypoglycemia, what we call the dumping syndrome. So, and this condition is mainly due to release of what? Or rapid release of what?
Insulin.
Insulin. So this is early late dumping. You eat sugary fluid or juice, come faster because no time to stay in the stomach because no stomach. Blood sugar become very high. Insulin secreted in big amount. So become hypoglycemic. So the patient become hyper. This is why we don't ask the patient to have this fluid rich of carbohydrate. Must be in the food or bulky food or gel or something like that, because if the juice is not suitable for the patient. Okay, we stop now at this question, which is 1880. I will send you the answer of this question just as a guide. Next time